Yeah, the coffee, that helps, I know. But to get here on time, I'm really impressed. Okay. I have the honor to introduce our two speakers today. I am Sue Burby. Those of you that don't know me, I'm the Specialized Services District Representative, which means I kind of attend a lot out of district meetings for our special ed kiddos, and also work with the non-publics and home down in the district. I was asked to help moderate this as these wonderful people will be opening a site down the road from us on 212, that great big building that's going up. Parent care will be housed in the second floor of the addition, and I just found out a couple months ago when Richard loved how great the progress was going, they decided to add another floor. It was supposed to be 2 floors, first and second, and now there's a third, so it has delayed their opening, unfortunately, which I think is back to May 1st? Is that,
April.
April 1st.
Yeah.
April 1st. Okay. April 1st, and I think we're on time for that as well. You'll find out more about Prairie Care during the presentation, but you will get your mental health CEUs today. If you're not part of our district and would like that, if you haven't registered through Cupid and would like that certificate, you can take that with you, and I have it up here. We'll stop 5 minutes before, hand out your evaluation, and also ask that you please put down any ideas that you have for further mental health presentations, because they will be really close and we can tailor-make our professional development needs. That said, I want to introduce Andrea Vasquez, is that correct? Andrea is a seasoned therapist with over 7 years of experience as a clinical social worker, and she believes in the wraparound treatment approach to therapy that includes a patient as well as caregivers, siblings, and significant others. Jen Holper is the community relations representative. She's been part of Prairie Care since 2007. She also started as a social worker in the child adolescent partial hospitalization program. And we're going to find out more about what's the difference between partial hospitalization and day treatment today. So those of you that's a new phrase for, that'll get defined for you. Jen comes to Prairie Care with over 8 years of in-home case management experience. And can we just give them a warm welcome to these two folks?
Thank you. I presented a couple of weeks ago to a group of transition students, and they all clapped for me, and I was like, this is it. This is my Ellen moment. This is as close as I'm going to get to being like a talk show host and having everyone's attention. I'm Jen. It's Andrea. We have actually worked together right from the start. Andrea started about a month before I did at Prairie Care, so we've both been there just about 7 years, since we were a tiny little site in Minnetonka with like 8 staff at our site to now
Over 200.
over 200 staff in 3 locations and all that. So a lot's changed in the time that we've been working together. When I initially started at Prairie Care, I was the social worker. Andrea was the therapist in our partial program. So we've done quite a bit of working together. So we haven't rehearsed this presentation together, but we do work really well together. So we should be good. We should be all right. And also, I know a lot of you did take a survey before coming today, which we really appreciate hearing some specific feedback about your comfort level with mental health. Also, what are you looking to find out of today? And we have slides and a presentation and all of that to go around, but this is your time to gain more understanding about mental health and more comfort with talking about it. So we invite you to ask questions all throughout. If it would be better for you to not be just lectured at, but to have more of a discussion, we are completely open with that as well. So really take some ownership and make this your time to learn what you need to learn. We'll see if this will work for me. I'll have to do a little dance every time I advance a slide. We have to hit this one instead. So just today, what we plan on going over is identifying mental health disorders that affect our youth. We do have some of the top hitters as far as mental health disorders, not an inclusive list. So just some that you'll see more frequently or maybe have heard more about all along. We'll discuss the prevalence of mental illness, diagnostic criteria for some of those different illnesses, as well as what it's going to look like in the classroom. How would you know? When would you intervene? What would you do? All of that. And then talk about the resources as far as the continuum of care. So like Sue was saying, what's the difference between day treatment and partial hospitalization? And then we, like I said, time for questions all throughout. So this is just a list of what we're going to go over. We'll hit on each of those individually, and then just know when we're talking about symptomology, something to be aware of is listen for all of the similarities in the different categories. There is so much overlap in the diagnostics for mental illness that it gets really complicated trying to figure out, is it ADHD hyperactivity or is it a manic episode of bipolar that's causing this irritability and this hyperactiveness?
If I could say, the majority of the children that we receive in our programs have some type of prior diagnosis of ADHD, which tells you not everybody has ADHD.
Right.
So it's kind of a starting point.
Just some facts to keep in mind, some statistics on prevalence. The one that I like to really point out is the 1 in 4 people are affected by mental illness. So this doesn't mean they're all diagnosed and in treatment, but this means statistically 1 out of 4 people has a diagnosable mental illness at some point in their life. So when you think about the numbers, how many people do you know? We are all affected in one way or another by mental illness. We know someone, we're related to someone, we live next door to someone, all of these things. We teach someone, all of these things could be related. And also to talk about suicide. That's the 3rd leading cause of death. And that's really preventable. If we can identify depression early on, we can prevent suicides and save lives, which is hugely impactful, and that's the reason Prairie Care exists, is to save lives, to provide that level of care and save lives. So just a couple of more statistics, and this is the one I want you all to pay the most attention to. So I said 25% at some point in their lifetime will have a diagnosable mental illness. Half of those, the symptoms onset before the age of 14. So are we all high school, middle school, elementary, a little mix? High school today. So before age 14, so by the time they're in your classroom, they may have the onset of symptoms. And then this one here is also really scary for me, being in the mental health field. Only 1 out of 4 youth with depression are actually getting treatment for depression. So for every one you know about, there's 3 more who are struggling in silence, who don't know how to ask for help, who are fearful of stigma, of being judged.
Parents who are fearful of stigma.
Huge factor, parents being fearful of stigma. Do you want to talk about ADHD symptomology?
Sure.
This is the one you're probably the most familiar with in general.
It's kind of like Jen was talking about, whatever the child's dealing with, they're struggling with something. So you're often going to see some type of inattention, lack of focus, lack of self-care. So that's all can kind of look like several diagnoses. So that's why I mentioned that often a lot of our patients come in with ADHD. In my clinical opinion, I don't feel that a lot of our patients have attention deficit, but it can be manifested and present overtly as ADHD. So this is definitely something that, you should probably have a licensed psychologist who actually gives out specific tests related to this. I've heard other professionals say it can't just be observation, it has to be classroom observation in the home, kind of other daily social domains, but there's also specific tests for it. And so people who truly are specialized in this take it very seriously, and it's not just I think you got ADHD, within a 1 hour interview. So it's something, it's a very serious diagnosis. There's specific medications related to it. So impulsiveness, hyperactivity, inattention, there's the prevalence there, up to 7% of school-age children. Like I said, there's very specific medication regimen with that, and behavioral interventions. What do you guys know about ADHD, or what questions might you have about it? What do you see in your settings?
I have a question more than should ADHD be a 504 issue or a IEP issue?
Ooh, that's a good question.
We have every student, dozens of students, all have 504s for ADHD, and it seems like most of them, and counselors, maybe you can chime in on this, most of that diagnosis seems to come from the family doctor, as near as I can tell. So that's a pain in the ass. If you're saying,
Why is it a pain?
if you're saying that they probably might not have it,
Right,
but
right.
somebody just
The
parents
family
on
doctor's
doctor.
diagnosing it, it's not a psychiatrist.
Right.
Right.
So
And one of the things I think ADHD, as far as mental illness diagnoses go, this one's pretty approachable. It's not as scary for
We call it like
parents.
safe.
Oh, they love it. They love
Yes,
it.
it's very safe.
Yeah, so parents are more likely to, oh, okay, I've heard of that. I know there's treatment. I know there's successful people in the world dealing with this. I know it's not real risky for suicide. It's not as scary as some of the other mental health issues. And then there's also the shortage of child and adolescent psychiatrists. So if a parent says, my child needs a psychiatrist, they can call and get an appointment 6 months from now, or they can go to their family doc and say, these are the things I'm worried about. One of the things Prairie Care is doing to help try to balance that out a little bit is that we are part of a collaboration to provide psychiatric consultation to family practice docs and pediatricians. So they can call from 7 a.m. to 7 p.m., talk to our triage social worker about what they're dealing with in the office, the kiddo in particular symptoms, what they're thinking the course of treatment they're recommending would be, and just get that viewpoint from the child adolescent psychiatrist as well. So we're trying to balance that out, and we're also providing some extra training to about child and adolescent psychiatry and behavioral health meds to pediatricians. So we're working on it, but you're going to see that a lot. And I think to answer the question of is it an IEP or a 504 issue, it's our favorite answer of it depends.
Right.
So what social supports does the student have? What kind of in-home, what kind of support are the parents
I was
providing?
going to say that. What makes me nervous is when I see they're just getting medication.
Yeah.
And it's, where's the in-home work, or is the family receiving treatment? And that, again,
Coaching.
it's really easy to label ADHD. Like my child has ADHD. So, and again, in my clinical opinion and working from a systems perspective, as a teacher, can you tell your school social worker, your school counselor, like, what's the family doing? In my clinical opinion, I think there needs to be more than just medication. So with that, if they're going to get these services, what other services are they getting? That's what I would say.
Yeah.
When you talk about medication, I mean, we have so many kids that are labeled with ADHD that aren't taking the medication. That if they're misdiagnosed, the medication probably isn't going to be effective anyway. But
Well, it
parents,
depends on which medication. So our chief medical officer, CEO, Dr. Overstar, will say, we could give everybody Adderall,
Right.
and we would all concentrate a little better. So you see an improvement, even if it's not the
Right.
accurate diagnosis, because it's a medication that helps people focus.
Which then makes it even stickier.
Right.
If it is helping a little
Right.
bit.
Right. So it depends on the medication, and if they're not taking it and you're seeing issues, what's your question about that if they're not taking it?
well, I think it becomes a power struggle then between the kids and the parents. The parents want the kids to take the medication, the kids don't want to take the medication, and then we see sort of the, I don't know.
The downward spiral. of
Yeah, I mean,
change.
we see it here at school, and
Yeah.
I guess, I don't really have a question, it was just a
Okay.
concern with
Yeah.
the misdiagnosis and the over-medication.
And we'll continue to touch on that theme because that is always hard with children and adolescents. I don't like the taste of it. I don't want to be different. I don't want to have to go to the nurse's office to take medication. I don't like the way it makes me feel. I just kind of feel blah. All of these things come into play, just like with adults. But adults can usually rationalize, I know this helps me feel better. I need to take my medicine so I can get to work. Kids need a little more help with that. And one of the things that I know another of our psychiatrists I've seen present quite a bit, Jane Marie Sulsley, talks about is having a conversation with the kids about what are their goals in life? What do they want to accomplish? And is there a function for that medication to help them reach that goal? So if they have a certain profession they want to be, or if they want to make friends better, is this medication going to help you in those relationships to not interrupt all the time? To not be doing those annoying things that friends are like, I can't handle it anymore. So we want to get the kids to understand the function of the medication in terms of their lifestyle and how it's going to be beneficial. Does that make sense?
And it truly has to be a kid's ownership in taking the medication. At many meetings that I have for IEPs, we talk about the ADHD, and if you're not going to medicate yourself, I'm okay with that because I don't think everyone needs to be medicated. But then you better figure out how
Some
you can deal
behavioral
with it.
tricks
Right.
and strategies
You wanna
to
make it through
balance.
school,
Yeah.
because
Right.
what you're doing right now isn't
Not
working, and it's not going to get you where you want to be. So.
Yeah. And I like to talk to kids too about the fact that, everyone has something. So no one's perfect, no one's walking around in a bubble of perfection, that we all have something that we have to deal with and manage and cope with, whether it's we don't sleep well, if we have asthma or diabetes, or if we get pneumonia all the time. There's always something that we have to deal with. This is your something.
I wanted to piggyback on what Sue said. I've always wanted to write a book called I Have ADHD and This Is What I'm Going to Do About It. Because so often you'll find families and kids that say, well, I have ADHD, so I can't.
Right.
You know,
sure.
and it's not any ownership or, it's hard for them because they have ADHD. But it's empowering them what they can do about it.
Absolutely.
And that coaching piece is so important.
Absolutely. Yep.
8 years time.
All right, on to depression. So this is another one that's probably pretty common. You kind of know stereotypical what depression looks like. It's the kiddo who is kind of a flat affect, not real interactive, isolating, withdrawing, things you may not see visibly, but you could talk to students about are changes in their eating and sleeping habits, either one extreme or the other. So it's not a consistent, they always stop eating, it's one extreme or the other where the changes happen. And it's not just a change for a couple of days, but it's a sustained ongoing change in the way they're able to function. Irritability is huge, so just kind of that edginess always being there, always feeling like you're having the worst day ever is what I've equated it to. And then the one you may see a lot of is not enjoying activities that they used to. So if they were on a sports team or debate or something like that, or they were really involved and engaged in your class and suddenly they're just not. Just apathetic and don't really care about what's going on anymore. Those are all indicators for depression. Depression is also something that this prevalence being as high as 25%, this is from the DSM, when we talk about overall prevalence of mental illness being 25%, you look at that and go, wait a minute, everybody's depressed with mental illness? No, but it is one that people could move in and out of quite a bit as far as think about how you would feel if you were laid off.
Right.
Adjustments in life and transitions can bring about a bout of depression. It doesn't mean you're clinically depressed for the rest of your life. It means that you're showing signs and symptoms, you're having a hard time coping. Bereavement can lead to this. Your kids moving out and going to college could lead to this, or celebrations, either way. And the best treatment for depression is a combination of medications and therapy. So again, it's not just a magic happy pill. It's some work that has to be done, learning how to cope, learning how to manage those symptoms. How can I take ownership? And yes, I'm depressed, but I still have to get out of bed. Yes, I'm depressed, but I still have to go to school. I still have an assignment to turn in. That's my job right now, is being a student. Does anyone have any thoughts, comments, questions about depression in our youth?
Can you talk a little bit about how that affects learning? If you have a depressive
I'm just going to
body,
say, you'll see the significance of the of grades dropping. What was that?
Fogginess.
Oh, fogginess. Just again, so the thing about ADHD and lack of focus, the majority of the kids we see, they have some type of depression and anxiety, and that maybe it's not a full-blown major depressive disorder. So even think about mental illness, they can have some type of dysphoria, some type of dysthymia going on. But to recognize depression and anxiety, that's going to be the overall what we see, and it can get better. Some things that stand out to me when I did more practice more often, kids, how significant it is to join with someone. So whether it's, anyone in the school setting, I'm thinking of, there can be like a large fight that can happen like between kids, and they become isolated from their group of friends. Like that's a huge theme that I saw.
Yeah.
And they don't tell anyone, and they don't tell their parents. So that's a big one that can cause even suicidal thoughts. I just did a presentation a while back on suicidal ideation and how important it is to recognize they're not going to verbalize it. So it's you really have to be aware of their behaviors. What are they doing differently, like Jen talked about? What's a change in their daily habits? Whether they're connected with teachers, social worker, counselor, the lunch person. How important it is, like we do patient satisfaction surveys and they always identify who they connected with, whether it was the doctor or the psychiatric technician, therapist, nurse. And so they long to connect with someone.
And it's not easy to connect with someone who's not really giving you that feedback that, oh, I appreciate this, because they're feeling depressed and they're apathetic, they're flat, they're not giving you anything back. But what's inside, feeling listened to and heard and understood, are huge strides for them to be able to know it's safe when things do start to get worse, to be able to talk further about if they are having suicidal ideation and how do you react to that, and what do you do, and what do you say? Do you guys have any questions specific when we're talking about depression, or bipolar is probably the best time to talk about suicidal students? Do you have any particular questions, concerns when you've got kids in your classroom who may be having suicidal ideation? That's a big one.
Or some of your own experience with it, or in terms of recognizing that a student had it, or a student reached out to you?
Can you just tell me how you bring up that conversation?
Right, that's a tough.
Just like model maybe like what you might say and remember that this would happen. You know, pull up just out of passing time and.
Yeah, that would be a quick 5-minute block.
You can have 4 minutes and I'll give you a pass.
Yeah.
That's kind of how
Yeah.
it starts.
That's your world, so yeah.
They're not gonna tell you until you build rapport.
Okay, you got a report.
You have to
Now
build
Now
rapport.
what do you do?
I would say if they feel comfortable with you enough, they're going to tell you, or if you gently prod, they'll tell you. But
Show me what prodding looks like.
I can be the patient. Go, Andrea, show us your skills. Well, I think too, one thing to keep in mind is you have to say the word.
Okay.
A lot of people are afraid to say suicide. We don't want to plant ideas, all of that. You have to say the word if you're really concerned about it. Because I've asked a lot of kids, are you feeling suicidal? And if they're not, they're like, no, I would never think that. I would never hurt myself. I'm just really mad. And if they are,
they're gonna look down.
they look down, their whole body just kind of slunks down because it's like a weight just got lifted off them because now someone knows.
And they might not say, but they might shrug their shoulders as they're looking down.
There's indicators there that you're like, ooh, I just touched on a chord, that something is really raw there that we need to pay attention to. So it's not being afraid to really directly say, you know what, I've noticed that you're not really speaking up in class. Your work hasn't been turned in lately. I'm really concerned about you. I don't see you in the halls with your friends the way I used to. Is there something going on? It seems like you might be depressed. Seems like you might be having thoughts of not wanting to be here anymore. Or have you ever thought about suicide?
I'm
And then
really
see.
real.
Yeah.
Like, patients know who's trying to play the therapist and who's not. Sorry, I say patients because that's what we call them. So to be yourself, like I try to be so real as a therapist, and like the kids will make fun of us if you say, "And how does that make you feel?" Like, don't ask me that. Do not ask me that question. They are on to people when you're not being genuine, and so you just
That's why that rapport is
to
so
be
important.
real. Like, hey, how's it going? You kind of look down. Like, what's going on? Like I'm like, what's up? You know, even talking their language, they'll slowly start to open up.
Your counselors or psych can help you have that conversations too. So if you have some of those concerns,
Definitely.
let us know. We can do it together or we can do it.
Yeah, we use
Separately.
formatted suicide risk assessment paperwork with the kiddos, so if you have any concerns, let us know.
Can you share a little bit about what you do offer for social services so we know?
It's not a
It's
social
a-
or-
service piece, that's more of a counseling.
Oh, that's what I mean. What do you offer for counseling?
Support.
Support
Supports, yeah.
in the schools, so we
yeah.
can understand.
Yep, so if we have kiddos who, we think may be suicidal or depressed, we do check in, and we have a checklist that we go through with them. I mean, the teachers are the ones that see them on a daily basis, so
Right.
that's where the red flags, if you guys see any, you need to let us know. I hate to say it, but our caseload is over 400 kids, so we can't provide that therapy that they need. We do have one therapist that comes to our school on Mondays from the county.
Okay.
So for those kids who need that, we're able to connect with them, or we refer work with family to find a therapist outside the school.
Okay, so really the teacher's gonna have the rapport.
Yeah.
Yeah.
So even if you have the interviewing skills, you wanna bring the teacher with, and it sounds like that's what you do. So that the child feels comfortable, because they have someone safe with them, so you could do it all together.
And for those kiddos that we do know struggle with mental health or just are not in a good place, those are our regular check-in kiddos that we just.
And how
make
do
sure-
they come to you? Or how do you guys,
How are you aware that there are kids struggling with mental health?
Either that they've already been diagnosed and we're with an outside therapist, or teachers referred them or told us that they're struggling, or the kids have come to us themselves.
Or you have parent phone call.
Parent will come.
Okay.
Social media, we see stuff.
Yep. A lot of times our kids post it on Twitter, they don't realize that it's open to the public, and so we'll have an anonymous phone call where kids come in and they'll show us a Twitter page, and that's a really, actually a great platform, so we pull the kids in, we turn our computer screen to them and say, look, I see this is where you put, yeah.
And they usually want to be caught. Why, otherwise, why would they be posting it? The majority of our patients have this. We have kids who get so caught up, I mean, it's like, I can't even explain it, like they're verbalizing their entire life on these things. And it's causing bullying, and someone was accused of like falsely imitating that they were being bullied. It is such a problem, this social media, what we're dealing with. But to go off of what you were saying, how important it is if you can connect with the outpatient therapist. I know when people get really busy, and I know when I have my own caseload, and my sister's in special ed, and she's like, I'm not allowed to talk to the therapist. And I said, are you sure? Ask the parents, get a release of information, push for it. You know, because it's like, you know, that person's doing something else, and you guys are in the school, it's like everyone should be working together. And I don't know how often that happens, but I can't stress how important that is. To get, you know, even if that therapist comes in and sits in class one day, to make sure that you're all doing that wraparound approach. But
And that's one of the questions. Those people, 30 of you, filled out in the last 5 minutes of school last week, and even over the weekend, a survey. And one of the questions and comments you gave, in my experience, the communication with school staff regarding the mental health component has been minimal. Can you talk about the relationship between the school component and mental health component within your program? And that's a part of why don't, and the other question is, why isn't the communication there
Right.
from that outpatient? And the thing is, there's so many, because of HIPAA, if you ask for a release and that goes through your counselor or your IEP manager if the student's identified, or if they're not identified, they're a regular kid who is experiencing these kind of difficulties, and you would like to talk to the parent, you need that parent permission if they're under 18.
So push for it, you know, I mean, don't just sit back, because people have big caseloads like you guys do, so it's very easy to not collaborate with all the providers.
The other piece about the release of information is to be as specific as possible about what information would it be helpful for you to have to be able to provide support in the school, and what information would be helpful for you to give. So on our releases of information, there's a checkbox for whether we can release the diagnosis, what medications they're on, the treatment plan, any psychological testing that they've done. So if the parent doesn't check those boxes, our hands are tied and we can't give you that information that may be really helpful in supporting the kids back at school. So it's that two-way street of us working and educating the families about, nope, the school really, they're not being nosy, they just really want to be able to keep your kiddo safe and thriving through that academic world. And so what tools can we give them by having them understand the diagnosis, or what medications, or if they're on a medication that may cause sedation in the morning, can we get an accommodation that they start school a little later so they're actually clear and present when they get there in the morning. So talking about all of those different things and educating the parents about why you want that information is really helpful as well.
I had a patient in the last couple of years who became very close with his paraprofessional, to where he started to use the para as his therapist, and he was reporting he was suicidal, and nobody reached out to me as the outpatient therapist, and I got on that. And we developed a very good relationship with the para. Admitted he struggled with enabling, and he didn't know how to put limits, and my patient was basically putting everything on the para. He was calling him at home 50 times a day, he was texting him. And, you know, if I did not put us all together, I can't imagine. And it was some tough times between the mother, because I had a lot of rapport with the mother of my patient, but saying, I'm not okay with this, we need to figure this out, and we need to get the principal involved. So that,
To support the parent.
yeah, so I think it's a good example, and my patient's doing wonderfully in college now, but it was a pretty difficult situation, had I not joined us all together to figure out what was going on.
Don't you think a lot of this too, looking at all of these issues, it's time? I mean, most of us, if you're working
Yes.
full time, we're seeing 170, 180 kids a day. The counselors have caseloads of like 3, 4,
Yeah.
500.
Yeah.
I mean, our function is, I see, certainly I'd love to help and support this and talk to the counselor and help coordinate all this. But like, the reality, that's the ideal, but the reality is here. And then just my other comment with all this too, if the family doesn't really get involved in this by committing their time and their money, I mean, that's why people don't get these services, is because it's just kind of new that now people have to have insurance, right?
Mental
Have
health coverage on
piece.
that insurance.
But
Right.
people have, $10,000 deductibles. I mean, it's just,
Yeah.
That's the reality of it, because when you do these kinds of services, I just had some issues with my son, it takes a lot of time.
Yes,
a
it
lot of
does.
energy and a lot of commitment, so the parent has to be able to take them there between.
Yeah,
4,
take
5
off
o'clock
work,
and-
transport.
I mean, it's really,
It's
you
huge.
sign up for a lot, it's very important, it's very helpful, I'm not saying it, you know, it's not because it's how else you're going to change
Right.
habits, but like,
Right.
that's why this is a family.
Right.
I
But,
mean,
so if all else
what's our role in
fails.
that, I guess?
Right.
I'm just feeling very responsible right now, and
Yeah.
like, what do I do with that?
Right, so my comment to that would be, if all else fails, how important is that they do connect with someone? It doesn't matter what position. If all else fails, at least they have someone they can go to on a regular basis, whether it's a counselor or the teacher or the gym teacher, anyone.
Professional,
That might just be
some
enough.
support, some adult who can kind of keep that extra eye to know if things are escalating to the point where more needs to be done.
But yeah, we hear ya.
And if you do have concerns, please go to your school site and your counselor, at least share those concerns. And they
Oh,
can
yeah,
help
I think we
with
talked about, it, we're all in the same boat,
Yeah.
I mean, we're just like
Everyone.
overwhelmed, and we're just putting out fires, and.
Yeah. Yep.
I guess.
One of the things I'm doing, hopefully on Wednesday, I had a young lady who was actually admitted to a psych ward a week ago, and they kept her all week. And she'll be coming back tomorrow. And I talked with Mom last night, and I said, I'd like to really have all the classroom teachers together, and you and the counselor, so you can kind of share what's going on, and what is our plan going to be moving forward. She had already had a permanent pass from her counselor to come to see her on a weekly basis, and her eyes had just lit up, because that was kind of her ticket to know that she had permission
Yeah.
to go
To ask for
somewhere
help,
when
yeah.
she needed to see her counselor and just talk. So hopefully that will then help with at least that young lady, because we aren't getting anywhere academically because she can't mentally handle it.
And I mean, maybe this is time to talk about our communication with the schools, like when they're in our programs and sending them back. I mean, even we have intermediate district 287 teachers in our programs. They struggle as well because we try to have all these school staffings to get everyone together, maybe some of you have participated in some of those, to get the kids back. And so it's everyone trying to find time. And it's like, okay, we can do 8 to 8:30 here, 9 to 9:30 here. I mean, we are trying so hard, but right, even if we set them up, it's like getting everyone together. And the school schedule's a little bit different than our programs, because you guys start like at 7, and our programs start at 8. And so it's like, well, we can do 7:30. Well, our staff's not there yet. But so that's I'm working on a huge performance improvement project related to this, but it's trying to get everyone together, because that is ideal. That we do aim for that, but I know it can be really tough with resources and people's time.
So we'll move on and talk a little bit about anxiety. And this one thing that I think is tough about anxiety is that we all have and need to have anxiety at certain times. This is something that helps us stay safe and stay alive and out of danger as we get escalated and we are able to get out of danger's way. But when anxiety gets problematic is when you get stuck on that loop and you can't stop the worry, the excessive, rumination about that one source of concern. So it may start out as test anxiety. It may start out as, I really am an introvert and these calls are madhouse when all the kids are in them during passing time and I just kind of get panicky every time I'm out in the halls, and that may escalate into something more. So really being able to talk about normal anxiety, like I have a midterm coming up and I practice my coping skills by making a list of all of the things I need to do to prepare, and I study and I read and I go to class, and sometimes when I'm reading I even have some aromatherapy open in the room to help me continue to deep breathe and to stay calm. And so really reinforcing some of those coping skills that we use every day. How many people, when you're stuck in traffic and you're late somewhere, you're just white knuckling it because you're anxious and you're worried about getting on time, so you need to use your coping skills, whether it's deep breathing or turning the radio up, but helping to normalize with kids that using coping skills isn't a sign of weakness, it's just taking care of yourself. When we're hungry, we eat. That's a coping skill. When we're anxious, we need to do some sort of a coping skill, whether it's exercise, medicine. Medication can be helpful, cognitive behavior therapy when things start to escalate into a different place.
This is the main focus of our inpatient and our partial programs. School refusal. In all my years of doing family therapy, I do not have the answer of how to get parents to believe you that they still gotta go to school. All the way from mom calling the kid in sick, and And it's like, well, they call it sick, so it's legitimate. It is, such a struggle. Again, I think it's building rapport with parents. I've had so many families that say to me, if I just keep them in a bubble, my child will be okay. And this is, I've done a lot of research on overindulged kids in the past, and I'm sure you guys are seeing it. They call it the helicopter parents. So huge in our programs. But family therapy is a requirement in our programs. We will actually consider discharge if the families do not have a legitimate reason why they cannot participate. But it is really building rapport with parents so that they actually believe you that the child still has to go to school. They can't just disengage from life. And we see this so often. The desire to protect.
Yeah.
How often does anxiety kind of evolve into depression? Because we have students who
Oh, it's
parents
overlaps
themselves.
often.
Yeah.
Yeah.
Very
And
common.
it's the chicken and the egg discussion, which came first, the anxiety leading to feelings of depression and isolation, or the depression and isolating leading to, now I can't do it, I don't feel capable, and the anxiety piece. They are so connected a lot of the time. And the cognitive behavior therapy is a really helpful tool for anxiety and for depression, so it's like a 2-for-1 when you do that. Do you want to talk more about cognitive behavior therapy? I can give some examples of groups I used to do.
Yeah, it makes me think of, so really, people who are depressed have many more negative thoughts and positive thoughts. I think I was taught you need to have 10 positive thoughts to 1 negative. And so I like to educate kids on how powerful negative thoughts are. So really retraining them, we develop habits of the way we think about things and the way we view things. A lot of our kids have that all or none thinking. It's all terrible, they're all against me. So really teaching them to kind of change. That's where that DBT comes in, the dialectical behavioral therapy. Seeing different points of view of one situation. That's what that actually is all about. Behavioral therapy, again, we do a lot of that with our little kids as well, but just changing behavioral habits from going to bed at what time, not sleeping with parents. I mean, you wouldn't believe the things that we see. What else do I want to say about that? Tough one to sell. Tough one to get people on board, but again, this is where my clinical opinion, you got to have the family on board. Otherwise, I don't know how much better the patient's going to get.
This one's really hard for parents to understand because it's an irrational concern. They get stuck in a loop of something that's never going to happen, and so parents are like, well, it's not going to happen, stop worrying about it, done, I did my thing. And it's like best intentions trying to redirect them, but it's still reeling in their mind, the concern that they have that may be irrational. With separation anxiety, we have kids who are so fearful that their mom is going to die if they're not there with them, that they can't separate from mom to go to school or for mom to go to the grocery store in peace or any of those things. So really being able to validate without enabling.
Right.
So validate, yes, I know you're really scared of that. These are the things mommy does to stay safe, and I'm going to, be home in an hour, and if I'm not home in an hour, you can call me. And, how do we validate and enable at the same time? Because mom still has to go to the grocery store. You still have to go to school. Life has to go on. Yep, we're anxious and we're nervous and we're worried. We still got to do it. So
We do a lot of groups in our programs, and believe it or not, peer pressure is more influential than we are as professionals. And so you see a significant change. Like their first day, they're kind of nervous, but like by the end of the day, they're loving it. And they're all friends. But so that's why we have specific group treatment, because of they just, oh, you have that same problem? I didn't know that. And yeah, we can really see movement alone just in the group treatment. The other thing I just want to say quickly is that we do really work with the kids too. It is on them to learn new coping skills. And it's not uncommon for them to not want to do the work because it's uncomfortable, it's painful, it's change. Who wants to do it? And even the parents. I have a presentation where I say, parents, can't drop your kid off, you got to come in too, you got to participate. But so we do have discharges where they're just not ready to do the work. So it is a lot of talking about accountability, and things are not going to change until you are willing to make some changes. I mean, that's a lot of work with them.
And really that sense of ownership that we talked about as far as the ADHD, so being able to take control of that. And this slide is just here to talk about stress, because a lot of times kids with underlying symptoms of depression or anxiety will have stress exacerbate those symptoms and maybe act as a trigger. So that stress could be that homecoming's coming up and everyone has a date but me. or homecoming and midterms are coming up, and my parents are going out of town, and I have hockey 6 days a week, and I have my girlfriend's mad at me, and all of these things that happen can trigger
Breakups, a lot of that,
yeah, relationship issues.
to not minimize breakups.
And this, I think, is also where bullying comes in. I've heard a lot of discussion in the community about, you know, kids committing suicide because they were bullied. And I just want to point out that it probably weren't, it's not the 12-year-old bully's fault that this child committed suicide. It's probably an underlying mental health issue that wasn't addressed, and the bullying was that trigger that exacerbated the symptoms that led them to the hopelessness and the suicidal ideation and actions. Does that make sense? That we as a culture need to take responsibility for that, that we can't be putting it on kids who are bullying, because kids are bullying. We know that. We need to address how people are reacting and coping to stress, and we need to make it okay for people to ask for help when they're feeling some of those underlying symptoms of depression, anxiety, or whatever it may be.
Not uncommon, we get kids in AP classes who are really struggling. They become suicidal, the anxiety, the perfectionism is like out of control. Parents are pressuring for them to continue to stay up on those classes, and the kids are just suffering. So we definitely need to see that as well, like the overachieving. They can just kind of put them over the edge.
So PTSD, we probably don't talk enough about. I work very closely with Laura Matz, who is clinically trained in trauma treatments and mind-body medicine and all of this, and she thinks that trauma is also very underdiagnosed. And a lot of the symptoms of trauma, again, this is where we see a lot of that overlap. Is it depression, or is it a response to trauma? Are they isolating because they're depressed, or are they avoiding that area because that's where a trauma occurred? So looking at really that's why we need good clinical assessments when we're worried about kids with mental health issues, to be able to kind of root out which is causing what and where and how and why and what things people have dealt with. So trauma, history of a past or recurrent trauma can result in intrusive thoughts. So sitting in the middle of math class, they might hear a sound that maybe happened during the trauma that you don't really associate. Like if they were in a car accident and there was a bike bell that went off, and then they hear the bell outside, and their body gets triggered back into that trauma. Our minds don't know the difference between a memory of trauma and the trauma actually happening. So we get put back in that same place. So really getting trauma-specific therapy is necessary. So if we're looking at it and saying, oh, this looks a lot like anxiety, it does. But if you're getting anxiety treatment and not trauma treatment, you might not see those benefits of the treatment. Does that make sense?
And this goes back to research shows as well with trauma. It's not so much what happened to them, yes, that's important, but the most important is how they were supported afterwards. So again, if they just have that one person, you know, in this entire school, I heard there's 1,400 kids here, even a good friend, you know, someone that they know they can trust and they can go to, that might just make all the world of difference.
I have a question on that. We often think of a horrible event that happened to somebody. It doesn't have to be that.
Right.
It can be that person's interpretation of the event.
Self-defined perception of life or death. So if it's a kid got beat up in the hallway, that victim could perceive that their life was in danger, whereas everyone else would go, oh, he clocked you once or twice, it's a kind of normal schoolyard fight. If that victim perceives their life was in danger, it can fit this criteria of trauma.
And it's so important, the homebound plug here, our kids that come back from cancer treatments, they come back from a life-altering event for them. And they're sitting in their classroom and they're looking like they're paying attention, and they're going to extracurricular activities, and they're failing. And it's that emotion processing of the event that they just went through that they say they're fine. They look like they're fine. They act like they're fine, especially after school. They want to connect with friends. They can't process the new learning that you're giving them because they are still masking the trauma that they really haven't had a chance to cope with and work out. So that's a hard one to call because they look like they're cheerleaders and they're doing great, but they went through an event that they thought they were going to die, or their family thought they were going to die, and they, influenced
Right,
Yes,
parents can be
absolutely.
going through their own PTSD situation. which-
Secondary trauma, yeah. Yeah. I'll let you talk about bipolar.
I mean, so one, again, this is my clinical opinion. Bipolar is, the prevalence is like between 1%, I think 3%. What does it say
1%
there?
of the general population.
So it is rare that someone has bipolar. And technically, you're not supposed to diagnose it until they're 18. I would say this is a little bit more like the ADHD, where children are given the diagnosis when they probably, it's something else. It's probably anxiety, depression, or PTSD. You know, I can tell you what I've seen. What is the new diagnosis? So they're trying to help people. Does anyone know?
It's
like an affective disorder.
Yeah, it's,
I should know this.
I
but-
can't remember the name. We have a new diagnostic book.
Yeah.
No,
No,
not
it's-
seasonal, it's
That just came out.
It's to help
It's
so
a
that we move
behavioral
away
based.
from giving such a big diagnosis we don't know for sure if they have it. So the DSM-5 has now incorporated that. I mean, these are, people with true bipolar have significant mood swings. When I work in an inpatient setting, these kids are actually probably psychotic. They're talking to themselves. They're not sleeping for days. They call it like a superhero effect. I had one patient who said,
Grandiosity.
yeah, he stood up and like told his teacher off in the middle of class. And once he stabilized, he was like, I actually told off my teacher in front of all the kids in the class. I mean, right, so we had so many parents like, oh, my child has bipolar. And then I
They
started
have
saying,
mood swings.
Yeah.
Whenever I set a limit, they slow.
yeah. So just to be aware, it's rare. It's really rare, but you know, if you do see just almost odd behavior, you know, you want to bring it to the counselors and say, I think we got something going on here.
The grandiosity, I think,
Yeah,
is
that's-
really big. I can remember a kiddo that we had who came in and was convinced that ants were taking over the world and that he was the only human who could communicate with them. I mean, he had the whole ant militia coming for us. But that kind of a thing where we would say, okay, ants, because they're like, they can carry 4 times their. I mean, he went into it
That's
really
a
seriously.
true manic episode.
That's a grandiose.
Yeah.
I am king of the ant military.
Can you just talk a little bit about the length of the cycles? Because I think in casual conversation, people will describe it as, yeah, exactly.
Right.
Really
It's like,
fast, back and
for a
forth.
half hour, they were like this, and then they were like this.
Yeah, what is it they say for a 2-week
Rap-
period?
And rapid cycling, I think, is like a 24 to 48
Right.
hours. So that's the fastest you should see the swings from up to high. And just something, a reference that you guys can look at after the fact as well, is that Ken Barlow, who has come out as bipolar, has done some amazing talks, giving really good references to how he felt at manic versus how he felt at depressed, and he's been very open about it. So I'd encourage you, if you want more understanding about that, he's got some really good talks that he's done out in the community about that, and I'm sure there's some online somewhere. I know he was a part of the Make It Okay campaign that TPT is doing with NAMI, and Prairie Care is a supporter of that. So really just making it okay to talk about your symptoms and what kind of help you get and how and why. The treatment for bipolar is complicated. It's a complicated disorder, and so typically kids with true bipolar disorder are on more than one medication. They need a lot of support, social supports, informal supports, all sorts of supports to help them to stay on that even keel. And this is one where I've seen the most trouble probably, and in my in-home days, I worked with a lot of parents who were bipolar, and they didn't want to stay on their medications because mania felt good. So just something to be aware of when they're experiencing a manic episode. They have a lot of energy and they feel great and they want to hang out with friends and they don't need to sleep and they can get so much more done and it feels pretty good, and you go on meds and you're just having a normal day and there's nothing really exciting about it. And so it's a hard adjustment to make.
You'll know if someone's truly manic. You're gonna know something's wrong here. It's not just gonna be a mild mood swing.
There's a lot. Racing thoughts is another indicator. So they will cycle through 12 conversations in 30 seconds. Like they will go from one topic to the next, 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 and you'll be like, I'm still back there. I don't know what's going on.
When I see this diagnosis in little kids, I say, so what's going on at home? That's my first question. Because there's probably some type of chaos going on within the home. And where's the family work?
Well, we've kind of been doing case
Yeah.
studies the whole time. So does anyone in here have any questions about PTSD or bipolar in particular?
Is it common for someone who's a cancer survivor to get psychiatric help after treatment?
Oh, we see all different kids with different type
Chronic
of,
disorder.
yeah, we see a lot of that.
issues.
You know, do the hospital social workers make referrals? I don't know a lot about that, medical floors.
I think it seems to make sense that they should have it, but then again, I think that, you know, we should all have once a year well checks with therapists, so that's just me. How are you coping? What's going on? How are you managing yourself? And kind of take the preventative stance on it. So I think that people dealing with a chronic illness and a life-threatening chronic illness, like Sue was saying, I mean, that's traumatic. You have every moment you're with your child thinking, are they gonna die? Is this gonna be the last time I get to hug them? That's hugely traumatic for everyone. That's a huge adjustment to go from, I need to keep you safe and keep every germ away from you because you're undergoing treatment, to, I need to treat you like a normal kid because you're in remission.
That's what we get.
That's the part that we get. So we get the parents, the helicopter, like hover,
And the
don't
patient
put you far
is like,
away.
I can't do anything without mom and dad. I mean, that's what we get.
Really wanting to be a normal kid and go through the motions. And it may take time just going through the motions before they can actually feel normal again, but having the support to be able to work through that.
Could you talk a little bit about the prevalence of PTSD in immigrant and refugee populations?
That's a great question, and I don't have a lot of research about it, but I'm sure it's got to be astronomical. One of the things I would direct you to is we have, I mentioned Laura Matz earlier. She is doing she's actually in her 3rd year of doing this, but she is working with the Fair Oaks Elementary School in Brooklyn Center, and they have a really high refugee population. I think they have like 14 different first languages spoken at that school. That's a preschool through 3rd grade population. And so what she does is she goes in and she does 4 trainings a year to the entire staff. So when Andrea's talking about being able to connect with anyone, it could be connecting with the janitor, because the janitor at Fair Oaks Elementary is getting this training about trauma and about mind-body medicine and seeing signs of distress and helping kids to de-escalate and use these skills. So she does that 4 times a year, a half-a-day training with the entire school staff. And then she goes in once a month and works with the student assistance team to do some kind of case consultation. And then that team also says, okay, this teacher has 4 kids in their classroom and they're struggling to implement some of these strategies. So Laura will then go into that classroom and provide coaching and mentoring in the classroom on the implementation of mind-body strategies that will help the whole classroom. So the goal is to address the student population who's been through trauma and refugee camps and transitions and new culture and all of these things, but to address the whole population so that everyone is aware of all of these issues and able to help and intervene and support. And they've seen a whole shift in their culture. They've seen a de-escalation in the number of trips to the principal, the times they've had to call police, the times they've had to restrain kids due to safety risks issues. All of that's changed. So there's a white paper on our website about that project.
Does anyone feel like they have an effective approach with kids who are struggling, who like want to brag a little bit? Or that you found is helpful to build rapport with someone? I don't know.
Easier said than done. I think the question that was first brought up, can you model some fluency with that vocabulary in talking to a student that you have concerns about, is important. And I think it's a great question, because that's the number one. It's the mental health piece that it's okay to talk about, and describing what you see is important. I noticed this, I see this.
Yeah.
Because lots of times they don't even get it, that they,
Right.
these are the signs that I see.
Yeah.
And being able to, it's not you,
Right.
but putting it on you, and I'm concerned because I see this. And then giving them the avenue to open up a little bit, because it's the you aren't participating anymore, that's what will shut them down. You aren't turning in your assignments. It's the I see that gives them the license to reflect and look at themselves and maybe open up a little bit more.
Yeah, everything Sue just said.
Well, it is, it's, and I think that part of it too is not being afraid to say the words and letting kids know, you know, it's like with, I'm thinking back to when people have talked about chronic fatigue disorder and how they felt just no one was listening to them and no one heard them and it's something real that's going on. And so just having someone say back to you, gosh, it just seems like something's up. I'm really concerned because I've noticed A, B, and C of symptoms. And, you know, I know that there's effective treatment or help for that. And do you want some help getting connected? But making it something approachable.
Right.
And you're going to have to bring it up. You can't wait
Right.
for the kids to come ask you. So it's kind of on us grown-ups to be grown-ups and talk about something that we may not be super comfortable with, but knowing that you don't have to have all the answers immediately, but reaching out and being willing to walk with the student. You know, you haven't met your counselor before because she's got 400 kids she works with.
Right.
So I know the counselor. Can I walk you down to the office and just tell the counselor what my concerns are? Maybe you can talk to the counselor then about that.
And they might even still have that look, but you know what, they're gonna walk with you.
Yeah.
Even though they might not talk,
Yeah.
they know you noticed.
It makes a big difference.
I just have a compliment to your facility.
Oh, thank
I've had a couple students there, and one thing that's helpful as a special ed teacher is to let us know when you have a discharge meeting that we can listen to
Yes,
that.
that's what we're aggressively working on.
Yeah, it's very important, because it's kind of scary for us sometimes as case managers, like, what should we say, what
Yes.
should we do?
Yeah, and
So
what
that's
we
really
like to
helpful.
do is actually have those meetings with the school a week or so before the discharge,
Yeah, that's
so that you
right.
have some time to prepare. And maybe, I mean, we also talk to the students about, what do you want to tell people? Like, you've been gone for a month. What do you want to tell people when you come back? Some students are very private about it, and that's their right. So we talk to them about how to set boundaries when kids are asking, why have you been gone? Why have you been gone? You know, you can say, you know, I was gone for a while. I had some things to work on that's really personal, and I'd rather not talk about it. But thanks for noticing that I'm back.
Yeah, that's
Like-
part of the treatment to get back, you know, when they leave, that we have to talk to the kids, what are you going to say?
Yeah.
Yeah. You know, we've had some situation where parents don't sign a release of information, and that can get us stuck because they don't want the school to know anything. And so we're trying to educate them like how important it is that we get to talk to the school. We don't have to share everything.
Right, but just for us, just to know,
Yes.
how do you deal with that? What do you tell people?
Yep.
Just- Yeah.
And I always, like, when I try to teach my staff, I say, schools want to know, like, what did we do differently? And what did we learn? And what can they keep doing in the classroom that we did in our programs?
Certain trigger words to help them calm back down, things like that. Autism.
That's a big one. You know, I know the DSM-5 is trying to change some of the diagnosing with this as well. This might be a little overdiagnosed. Again, I think this is something you're going to know. Significant impairment in social interactions, lack of eye contact, verbal skills. You know, there's the Asperger's and the autism. I was reading this, the prevalence could be as high as 1 in 88 children.
That's what Autism Speaks is saying.
Oh.
Yeah, that's where that number came from, 1 in 88.
Used to be 1 in 150.
It used to be 1 in 400 back in the day. And Jean Marie has a specialty in autism, and she just did a talk for us. And what she talked about is the difference in the diagnostic now between DSM-4 and DSM-5, which is the Bible of diagnosing, is really that it is a spectrum, but we're not going to have Asperger's and PDD, which is pervasive developmental disorder. It's all autism spectrum disorder now. And what's different is that there's different categories that the prescriber or the diagnostician has to categorize the intensity and the impairment in that area, so that you'll be able to see a more clear picture of where they fit on that spectrum. So really a delay in language skills. And since you're all in high school, kids are going to come to you with the diagnosis pretty firmly in place already. It's one that's apparent in really young kids. They're not developing their language skills. They're not engaging in play with other kids. There's a lot of outbursts and sensory issues a lot of the time. So tags on the back of shirts, seams in socks. Kids don't want to wear blue jeans because they're too structured and firm and uncomfortable, so lots of sweatpants, different things like that. And really, early intervention is the key for helping kids with autism be able to adjust to school. Lots of structure around transitions. is very important. So think about all the transitions in a high school day. I mean, every time they leave one room and go to the next, every time they put one piece of paper away and move to the next, go from working on something quietly to now you have to listen to it. They can get stuck on the first task, and the whole day they're still stuck thinking, I didn't finish math, and now I'm in gym 6 hours later, and I still need to do my math assignment. And so then one little thing might set them off to not like the last straw. So the kids with autism just can't take it anymore, and that's where you hear about aggression and outbursts and things like that, because they've had 14 transitions that they weren't ready for. So
You really want specialized individuals working, diagnosing this and working with these types of kids.
Is OCD on this spectrum? Because you said like the
OCD
seams in the
falls-
socks. And
Yeah,
Yeah, that
that
can
falls
run.
under anxiety, but there's high comorbidity with autism, with anxiety, OCD. and
I think if
depression.
you were to have to diagnose, autism would just be given and assumed OCD's within that. Yeah, I don't think they would give both diagnoses.
And there is a difference between educational autism spectrum disorder and
Yes, this is what my sister tells me.
DSM-5. It is possible to have an educational diagnosis, medical diagnosis of autism spectrum disorder and not qualify
Right.
under education. It is also possible to qualify under autism spectrum disorder educational
And not.
DSM-5.
Yes.
And your IEP managers can help you with that, and if you can say, I know this student clearly presents like this, why doesn't he have an IEP? And that any case manager, IEP manager can help you with that, because it has to prove that it's affecting their educational performance, and that also that social piece too, that it's impacting their lives. We had so many, I can't tell you in my 20-year career in this district, how many students have exited out of services because they did develop really good coping strategies. And I've been invited to graduation parties, and it's awesome. That they get it, they just need a couple accommodations maybe on extended time on a test or to help with their processing, but they've developed the social skills, they've developed the coping habits. They still have a DSM-5 diagnosis. They don't need that educational, they don't have that educational. And think about my generation, the quirky people in our lives, that we grew up with, like, oh yeah, and I remember this kind of,
That makes sense
and
now.
quirky in the way that they're making tons of money because they're geniuses.
Exactly. They know how everything works. Yeah, lots of engineers. And I had someone ask me too at another presentation I did about adults with autism. And what happens is, like Sue says, is they self-select into a career that's helpful. The technical abilities, the getting stuck and not leaving until it's done, those are helpful skills in certain professions, whether it's engineering or IT or development design, things like that. So just something to keep in mind, because I think autism gets a really bad rap. I think there are kids with autism who are amazing geniuses and who should be looked at in this way. Always unique, totally interesting, sometimes mysterious, because I think that's very true. And the mysterious part is we still don't know for sure what causes autism and why are these rates skyrocketing and everyone suddenly has autism. So there's a lot more work and research that will be done in the next 5-10 years. We've come a long way since I entered the mental health field, so I know we've got a long ways to go yet.
Any questions on autism or Asperger's?
So this is our continuum of care. Who knows exactly who to call when they have a mental health concern?
I actually have a question back on the autism before
Sure.
we move on. So you said Asperger's is not considered its own label?
It's not going to be.
No longer.
So
Yes.
where in the spectrum would that have been in the past?
Higher functioning. Yeah, so less impairment, but you still see the lack of social interaction, things like that, but they're higher functioning. So with lots of redirection, they are able to take turns and, okay, you need to look me in the eye now, versus lower functioning where it's look me in the eye.
Well, and kids with that can be even more complicated because they present so, like they're grasping everything you're saying when they might not be. And that can be difficult because they have better social skills than someone with autism. And we take some of those kids in our programs. But it can be difficult because they might not be taking everything in that you believe that they are.
They
They're
can
kinda
maybe fake it a little better.
Yeah.
So they blend in a little bit more, but then when you get one-to-one and ask
And you'll-
about
yeah.
something, you'll clearly see that there's an impairment.
Our owner, I think it was our owner, Dr. Sederberg, said that he worked with a patient for many years with this, and he said in all his one-on-one sessions, he feels like the patient just needed someone to listen to him, or like just to let him talk. But he never really cared what the doctor had to say. It was just someone to
Just kept talking.
just go, yeah, they just kind of keep talking. But there's like, that reciprocity isn't there, like the friendship. He just needed someone to hear all his ideas, and so.
So outpatient mental health therapy is probably our first step. And this is probably what you know the most about. So you go to the therapist, you're there for 50 minutes, you have your talk session, you go home, you maybe have some things you're supposed to work on during the week, you go back next week, you talk about how your week was. Typically this is somewhere where you will need a diagnosis so that insurance can be billed. A lot of outpatient therapy, whether it's a mental health clinic or a private practice setting, will also offer a sliding fee scale so that people who don't have insurance or can't afford their co-pays and things like that can also still access care. And hopefully these are all things that are going to be more accessible now that everybody has to have insurance that covers a mental health component. That's part of the Affordable Care Act, that mental health has to be a piece of the insurance that we get. So we shouldn't be getting people at our door saying, oh, we don't have mental health coverage. So we have insurance, but we can't get coverage for mental health. So we're hoping that that'll improve so that more people can access care, because that is one of the barriers to getting the help you need and those early interventions, which are so much more helpful than waiting. I think the statistic is that people wait about 8 years from the onset of symptoms until they seek help. So can you imagine if you had chest pains for 8 years and then you wouldn't make it 8 years. You would have to go to the doctor before that. So these could develop into life or death situations. So we want to make sure people understand that and are getting care as early as possible. And this is kind of a stepping stone to the highest levels of care. So outpatient therapy is very effective for a lot of people. For some people, it's not quite enough. So that's where
more the higher functioning, and I think our CEO says the worried well. You know, that's someone for the most part who just kind of needs a touch up, you know, but for the most part they're functioning in their normal activities.
So this may be where adjustments happen, you know, life transitions, and you're feeling kind of in the dumps and down, and you're having a hard time focusing and concentrating, or you're really worried about your kiddo who now lives in another state at college, and so you need to develop some skills and learnings for this next phase of your life. So that can be a lot of that piece. And in relation to kids, this is where, you know, I'm really worried because he seems really reactive whenever he gets frustrated. I'm talking about my own son here. Whenever he gets frustrated with homework, he can't deal with not knowing the answer right away. So he goes from being a really smart, good, great kid to being, I am stupid, I'm dumb, I can't do anything right. So maybe outpatient therapy would be an effective place for him to learn some of those skills, that there's a whole lot in between being great and being horrible. So let's learn how to sit with some of that and live with it and deal with it. So that's what outpatient therapy is for. Outpatient med management is, like we talked about earlier, going to your pediatrician or family practice doc, or if you're lucky enough, to the psychiatrist, to get outpatient medications. And do you want to talk a little more about, I mean, it's typically an hour appointment at the beginning to do a thorough assessment, and then like 15-minute to 30-minute med checks after that. Depending on the medication you're on, they could happen every week. They could happen every 6 months. Some medications they can call in for a refill. Some you have to actually go and get the prescription because of the classification of the medication.
And it's rare for our inpatient or partial programs that one of our patients doesn't have the outpatient therapy and med management in place. That would be really rare. They almost always have an outpatient providers.
Because the way mental health care works is you have to fail at the lower level of care before the insurance is going to justify the next higher level of care. So you have to first, it's like the least restrictive environment for schools. So you can't go straight to inpatient because you're really worried. You first have to try the lower levels of care to make sure that you're doing everything you're supposed to be doing. In-home therapy, case management, there is even in-home psychiatrists who go into homes and do med management in home. Dr. Rachel, I've heard of her, I have never met her, but so in-home therapy it's basically the therapist comes to you, and it's really helpful because then we can do some coaching of parents in their natural environment. So it's easier for kids to generalize the skill they're learning in their therapy to how they interact with mom or dad at home.
Do you know with the change of the insurance, because right now it's really only like the PMAPs and MA, is that going to change for in-home? Because in-home, a lot of it's not covered.
A lot of private insurers won't cover in-home
And I don't know
therapy.
what that's about.
I don't know if that'll change or not. Let's hope, because it's a great level of care. That's actually where I worked before coming to Prairie Cares. I did in-home skills and case management. So really supporting the parents. And a lot of the families that I would work with would have generations of mental health issues. So I would be working with the kids as my identified clients, but the parents would have a lot of mental health impairments that would keep them from being consistent with their kids or keep them from having consistent housing or maintaining jobs, all of those things. So providing support to the whole system through the identified patient or client. Next step up from that is intensive outpatient programs or day treatments. And this, I'll talk about these kind of together because they're very similar and they get confused with each other a lot. They both happen during the day. So they both get called day treatment sometimes because they happen during the day. The difference is intensive outpatient or day treatment programs are typically an educational setting with a mental health component. So they have some mental health groups during the day. They maybe have a mental health supporter or helper in the classroom to keep the kiddo on track and focused and kind of coach them through the day. But the focus is still educational.
And they might have like consulting doctors and therapists.
And those are typically their outpatient people.
Like they're not there on a full-time basis.
Yeah, so there may be a release to talk to the psychiatrist who they see once a month at another site. The partial hospitalization program, which also happens during the day, is a short-term intensive medical treatment, mental health treatment at a medical setting with a school component. So 2 hours of the day, the kids are in a classroom setting. They're working with teachers, they're doing homework, they're getting lessons, all of that, while being observed to see how they're functioning in that setting, but also the most of the day is therapeutic groups then.
So you have licensed therapists, nurses, social workers, OT, activity therapy, and they see a doctor at
2
least
to 4 times a week.
Yeah, our doctors are great. They see the kids like every day. We're very lucky. We have wonderful doctors. But so very intensive.
And the psychiatrist is on site and a part of that treatment team.
Yeah.
So what happens in partial is that if they already have, and most of our kiddos do already have someone prescribing their medications, that stuff gets suspended
Transferred.
or put on hold while they're getting this level of care, because that's a lot of therapy in one day. So we don't want them going to outpatient therapy and not being productive because they've already talked about their stuff for 6 hours.
And each discipline is expected to communicate with the outside discipline.
Yeah.
So doc to doc,
Our
therapist to
therapists call the
therapist.
outpatient.
Our school teachers call the school for the academic piece. They won't touch the clinical piece.
So the difference in how you get into these different programs is that intensive outpatient programs a lot of times comes from a school referral. So kids are not able to learn here in the least restrictive environment. They need the next level up. And so the recommendation is we can't educate them here. They need to go to the day treatment program until their behaviors, moods are stabilized, things like that. And that could be a 6-month span. It could be a school year. It could be longer. Partial hospitalization comes from, I don't know what to do. Things keep getting worse. We've tried everything we can think of. They're not functioning. They're not functioning at home, and they're really struggling with their peers. They're always in fights, or they're not even talking to people. Across the board, we need help. So they can come to us through a referral from their pediatrician, their outpatient therapist. The parents can call on their own, and it's a medical decision that this is medically necessary treatment. So now you're admitted to partial hospitalization.
Can I just add something to that? We don't refer kids to day treatment. That's a parent choice. That they can pursue that option. Yeah, we share information with them. We have one day treatment program that our district subscribes to, and it's out. It's part of the Southwest Metro Cooperative.
What is the
It's
name of
called the
that?
WOW program. And right now, I think they have 8 or 10 students on that one.
okay.
And it serves the members of the Southwest Metro Cooperative.
Is that
Now,
917, District 917, or is that separate?
that's
Okay.
But the partial hospitalization that they're opening up right here in Chaska will be serviced by
Chaska schools.
Eastern Carver County Schools. We will have 2 teachers. We have hired 1 already. Sarah Sands will be the teacher for the elementary part, and we're still in search of our secondary education person. And this person needs to have a special education license as well as a general education license. So it's very hard to find, but we're still looking, and we're just really proud of it. So we will be in charge of that communication piece for any student in any district that attends the 212 Center, that we will be communicating back.
Definitely.
So Sue, is the Carver Scott High School still,
That's
an idea?
Carver Scout High School is a,
They have that mental health component, correct?
they have they do have a mental health component to it, but again, that's a public high school that anybody can enroll with.
Okay.
Is that like a charter thing?
No, it's a okay.
Okay. So partial hospitalization, again, is functioning is impaired across the board, but they are safe enough to be at home at night. So they're with us from 8:45 to 3:45, and then they go home with their families in the evening. Family therapy, like Andrea said earlier, is also a mandatory component of that program. So every kiddo in the program is with us every day, Monday through Friday, and their families are in at least once a week for family therapy.
Our average length of stay on that is 21 days, just for you to know, and the summer less, summer more, but that's our average.
And then our inpatient hospitalization program, we currently have 20 beds in Maple Grove, and we're in the process of expanding slowly and then expanding really big. In the next 1.5 or 2 years, we'll have 50 child adolescent beds. The inpatient unit is for children who are in danger of harming themselves or someone else. So that's the standard level of care for inpatient. So if you go to Fairview or you go to Abbott, that's the criteria to get into inpatient is, yes, I am suicidal and I have a plan, or I have thoughts of hurting my baby sister, or whatever that may be. Or I can't handle my emotions to the point where I blow up and whoever's in my path could be at risk. So our inpatient hospitalization, the programming is actually about the same as what it is in partial. So they get groups all day long, they get 2 hours of school, they see their psychiatrist every day, 2.5
hours of school inpatient.
They see their psychiatrist every day, they have family therapy sessions at least once a week. Within the first 72 hours of being there, they have a family therapy session. They have a treatment plan they're working on, and we're working to get them back to that next level of care, that next level down, or sometimes up.
So if sometimes we go to residential, not uncommon that they step down to one of our partial programs, which is wonderful for continuity of care. Like in our Maple Grove, we have inpatient partials right there, so they can even walk over for the day and see how it goes. So they're still considered that staying on inpatient, but they can try out and see if partial goes well. Then they say, okay, we're going to discharge from inpatient, then you can start partial the next day. So it's really nice.
Any questions about inpatient?
I have a question about accessibility, because
Yes.
it feels like a big jump from the outpatient therapy to the intensive outpatient program, which is more educational. Do families, are there enough treatment programs? Do families who are feeling like they're struggling? Is there a waiting list? Like, I'm
Oh,
trying
yeah.
to think of kids in our classroom who are struggling with the therapy.
So what happens a lot is if outpatient therapy isn't helpful to the point where they're functioning again and able to be done with it,
Right.
you usually add on.
Right.
So by the time kids get to these levels of care, they maybe still have all of those other levels of care as well. And they're coming here because that school functioning is still just not, they're not able to cope with the school day. So they come in for intensive outpatient program, and then once a week they go to their outpatient therapist, and they also have someone coming into the home once a week or every other week and helping with skills and things at the house. So it's a progression that can be cumulative, or you can go from outpatient therapy and meds to inpatient. So it's kind of fluid in what's going to be the most appropriate level for you to get the care you need to be able to succeed back out in your world.
But this is why we're expanding. Like during the school year, I mean, the summer year kids are happy. Like our census just drops. We have to send staff home. It's amazing. And then as soon as school picks up, we can predict
Homecoming.
when we get like slammed. And so there's a waiting list right now for partial, there's a waiting list for inpatient. I just saw a patient who came from, I gotta remember to say this. Oh, from Chaska to Wilmer to us. So I went from Chaska to Wilmer to Maple Grove, and they sit in ERs, just waiting
Until a bed opens
until a
up.
psychiatric bed opens up. And so right now, and I literally see the social workers like
Running.
fighting to get their neck patient into partial. I mean, it's like a competition, and that's why we're expanding, because there's not enough out there.
So I know we were kind of, we monitor pretty closely the availability of beds, and I know I was in our needs assessment office, and in one 8-hour shift, they had 11 children and adolescents that they had to turn away for inpatient hospitalization because we were full and ERs were calling us. Do you have a bed? 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 11 in one 8-hour shift.
Is that because so many people wait
That's part of it.
a long time?
Well, your parents are so hopeful. They're like, we're gonna get them back in school and everything's gonna be fine.
Yeah.
And then it's like 2 to 3 weeks after school starts, then we start filling up.
Or, you know what, we're just gonna get through the holidays.
Oh, you wouldn't believe the holidays.
We're gonna get through the holidays, we're not gonna worry about, we have people coming into town, we don't wanna have, so-and-so out at the hospital.
What was it, the 4th of July?
Oh yeah, because
We
we're
were
going to the
dead.
lake.
And then bam, the next day.
We need to make
We
sure
have
that
so
we
many
have all of that
admissions.
ready.
So it's like they hold it together. It's because it's fun. We're all happy when we're on vacation. But as soon as that holiday's over, yeah.
So we've got about 5 minutes left. I see Sue's handing out evaluations. Please, if you have any questions or things you want to address, let us know. We kind of talked about this.
I know, I'm like, just do this.
So good. Very happy to hear that. It's great.
Okay, I wish we put that poster up in all our classrooms. I love it.
It's good. I found it on Google Images, so you can look at Google Images for mental health and find all sorts of fun, easy posters and sayings and whatnot.
I have all of your emails, and one of the questions that came up on the survey that went out was tips that, what I can be doing differently in the classroom. So when Minnesota Department of Education has, under their OHD manual, has a number of these diagnoses listed with educational tip sheets that show signs what it looks like in the classroom and also some things that you could do differently. So if you have a particular interest, like in that OCD or area or anxiety, please look up. I'll send you the link. Look up what you're interested in and then print those sheets off just for your own resources. I found it really helpful when I had to look up some things earlier. They took it down for a while and then it's finally posted back again. What you can, Tourette syndrome, there's some real specific things that are listed there. Now, what I'm passing out to you is for the whole day, so don't turn it in right now. I put 8A, that's your session you're in right now. What I am requesting though, that on the back, if you want follow-up, you want specific staff development training in a specific area, or more information, that's great, but you just scratched the surface, this isn't enough. Can you describe what you want and put that on the back? Because it's going to go to Arlene, and then our professional development committees will go over these results and make sure that you are listened to. And I can't thank those people enough that took the time to answer that survey. It's still up. If you want to answer it, I sent you all a survey. So it was really interesting if you want to know the results, because on a continuum of 5, how comfortable you felt, some people didn't even want to put a 1. One person just really made it known that there was no 0 possible, otherwise I would have put a 0. But the averages out of a 1 to 5 was your understanding and comfort level was about a 2.5. Symptoms of a mental health diagnosis, we look like we're all a little bit more comfortable with that ADHD. But bipolar, not so much. That was barely a 2.
discussing the mental health of a student with each possible. The student themselves, just a little bit over 3. Look at, I mean, that goes with our fluency and comfort level. You know that's even, if you know they have a diagnosis, yet how do we even approach them and talk about it? But it was really hard welcoming to me. Guess what the highest is? Special ed. Thank you, because I hope we're here for you too, and we want to help you serve kids the best that as we can. And now, your knowledge of what to expect when they turn from a mental health is treatment and hospitalization is barely a 2.
And if I could just touch on that a little bit, because I think that's really important to know, is that when kids come back from partial hospitalization or inpatient hospitalization, they are not in full remission.
No.
We get them back, it's that least restrictive environment of care. So we get them back to their home environment as soon as possible. So we get them to a point of safety. And we hope that they continue with our recommended discharge plans to continue to wellness. But they're going to come back and they're still going to struggle a little bit. And they're going to need time to reacclimate to the noise and the size and the scope of what it is to be in high school. And it's always going to be a little different for them. They're going to be struggling. Kids who come through partial or inpatient are not the adjustment kind of kids that we were talking about, where they may have some depressive symptoms, they work their way through it and they get back. Kids who come from a treatment facility are going to be dealing with their mental health issues for the long term, most likely.
And just sitting down with them one-on-one, if you're their teacher or their counselor, hey, how's it going? You know, really just letting them, just setting some time aside for them.
And I know I have a hard time with this one. Justice is a very high value of mine, and so I have a hard time thinking, oh, you're getting off the hook, you're getting off easy because you were in the hospital and whatever, when can we get back to normal? I have a really hard time with that one. Andrea, I'm sure, can remember from working with me as a social worker, like, but you need to be in group. Heather's freaking out right now, I need some time. So really being able to check your own values and be able to say, is this my need for them to be in getting all of the assignment done or taking the full test, or is this in their best interest? So whose needs am I meeting right now to be able to pace what kids are ready for and when they're ready, and just being open to talking to them about it. Like, how'd that go? You just took a test. Awesome. Was it really hard? Did you have anything you need to talk to me about? Do you need some time with a counselor? What can we do to support you and keep you going on the path so that instead of taking half the test, you're maybe going to take a full test next time. So, but taking your time and taking baby steps, I think is the most helpful advice I could give.
Grab a 15-minute break between now and your next session. If you don't know where it is, please look at the chart at the bottom.